Good afternoon and welcome to this month's Northern Virginia Health Policy Forum. My name's Jim Scott, excuse me, and I'm the president and CEO of Applied Policy based in Alexandria, Virginia. My focus and the focus of my colleagues is to help healthcare organizations navigate federal healthcare policy. We host these gatherings to promote an exchange of ideas and approaches to the multiple issues that define healthcare today. Three veteran reporters who cover the healthcare landscape on a daily basis are with us for today's session. They've agreed to share their expertise to shed some light on issues that are informing and will continue to inform the debate as we move through 2023. Our panelists are Julie Appleby, senior correspondent for Kaiser Health News, who reports on the implementation of healthcare law, healthcare treatments and costs, trends in health insurance, and policy affecting hospitals and other medical providers. We also have Maya Goldman, a reporter for Axios. Maya focuses on health policy issues in Congress and the federal agencies, including Medicare payment, telehealth, and price transparency. And we also have John Wilkerson, Washington correspondent for STAT, who writes about the politics of healthcare. In his more than 20 years of covering healthcare payment and regulation, Wilkerson has extensively covered policies that impact prescription drug prices. Before I call on the panelists, I have an important operational reminder for our audience. Throughout the webinar, please feel free to type any questions you may have into the Q&A chat box at the bottom of your screen. We will do our best to answer your questions in the latter half of the discussion. Let me begin by giving each of our panelists an opportunity to give us their top-line view of what's currently informing the healthcare debate. Let's start with John Wilkerson.
Hi, thanks for having me. So yeah, I'll start off with ADUHELM. I think we're finally starting to see the policy repercussions from that. I would divide them into two main areas: accelerated approval and coverage with evidence development. Accelerated approval is more of a FDA policy, but CMS is getting involved too. Yesterday, CMS said that one of the three drug pricing demonstrations that it plans to test would involve potentially paying less for drugs that have been approved via the accelerated approval route until they finish post-market confirmatory trials that show that their drugs actually work as have been predicted. Coverage with evidence development is another interesting area. MedCAC yesterday actually said that it is looking into updating guidelines for CED, which is fairly interesting. I don't know if that's a direct result of ADUHELM. It probably isn't, but it still fits into our talk here. Also on accelerated approval, it's interesting that there's a bit of a double whammy because FDA, has more authority now to enforce confirmatory trials, and then like I said, CMS yesterday said that they're looking into paying less for accelerated approval drugs. So you have both agencies moving on that one. And then in negotiation for Medicare negotiation, that's another big area that we're tracking here. That's going to be a huge bureaucratic undertaking. One of the difficulties is just hiring enough people at CMS. My understanding is that they're already starting to borrow from within the agency, especially CMMI, which is kind of interesting because CMMI obviously has its plate full too, as I just talked about with their demonstrations. But as far as how that's been going so far, CMS on September 1st is supposed to initially give the initial list of 10 drugs that it will negotiate. So that's a big thing to watch for. CMS recently said that it's going to delay the inflation rebates until 2025. So that's, fairly remarkable. And a lot will be covered in regulations. in the lead up to actually negotiating, there will be all sorts of things that they'll have to work out, such as, their approach for considering data and evidence, the process for drug makers to make counteroffers, how FDA or how HHS explains its decisions on final prices and so forth. But I think probably the most consequential thing to watch for is how aggressively CMS negotiates prices once it actually starts negotiating prices, and that will take time to suss out, and it may shift over the years. That won't just that could affect not just brand drug prices, but also things like like generic competition, whether biosimilars get developed. So I think on negotiation, it'll be a while before we really understand how impactful that is. And there's a lot going on the Hill, but I'll actually let Maya probably jump in on that. I would just say in general, you have two camps. One camp says nothing will get done this year, and the other camp says that divided government makes for compromises. So there are plenty of areas that could be worked on this year, next, and we'll see how that goes.
Thanks, John. And Maya, you want to give us a top line view of what you're covering?
Yeah, thanks for the preview, John. I'm Maya. I write for Axios. We just started a new newsletter on health policy in Congress. So quick plug to sign up for that. But I spend most of my days up on the Hill, running around, figuring out what's going on in the healthcare world up there. And so as John said, it's a lot of people think it's going to be a tough year to get any big reforms through Congress because of the divided government. So one of the things that I'm watching really closely is all these different healthcare funding reauthorizations and what, if anything, rides along with those, because it seems like those are pretty much must-pass legislation pieces. So that's PAPA, the Pandemic and All Hazards Preparedness Act. The Support Act needs reauthorization this year. There's a delay of Medicaid dish cuts from the Affordable Care Act, community health center funding. Those are sort of the four big buckets, but there are a couple others too. And then there are things that I think Congress will lay the groundwork for this year, and advocates and lobbyists certainly will lay the groundwork for this year that we will start to hear people talk about more. And that's the big buckets that I'm hearing about there are Medicare payment reform for physicians, Medicare Advantage, transparency and overpayments, and what we might do there. The 340B program, there's been a lot of interest in doing oversight of that. And then two areas that are pretty bipartisan that we're definitely going to hear about more, but maybe even we'll see some action on are PBMs and the healthcare workforce. I'm interested to see where those conversations go. And then, of course, there's going to be a ton of oversight in the House this year. That's a lot on COVID origins and the fentanyl crisis and things like that. So keeping an eye over there. And then, of course, looming over everything is the debt ceiling discussion and whether there will have to be any cuts to or reforms to entitlement programs, specifically Medicare and Medicaid because of that. And that's a big debate. What counts as a reform? What counts as a cut? It will be very interesting to see where Congress lands on that. So I know that's a lot, but there's a lot going on the Hill always.
Thanks, Maya. And Julie, your opening statement?
Yeah, great. Thanks. I am so glad that John and Maya are on because I don't cover Congress. So I'm glad that you guys do. I tend to look more at sort of the what's going on with employers and insurers and trends and things like that. So let me just say a couple of things. I personally don't cover Medicaid or abortion politics, but those are obviously going to be really big issues this year. We're going to see a lot of state action on that. We're going to see states start to reevaluate the folks that have been on Medicaid and throughout the pandemic and couldn't be kicked off. And now they're going to start looking at income and other eligibility requirements. So we're going to hear a lot about what happens to some of those folks. There's an expected, several million people may lose their coverage. So that's not something I personally cover, but my KHN folks do. And just to give a little plug, Kaiser Health News is an editorially independent program of the Henry J. Kaiser Family Foundation, but we often get mixed up with the insurer with a similar name, but we're not part of them and they're not part of us. So just giving that little plug. So for what I'm watching, I'm always watching the cost issue. The rising cost of care for employers and insurers is going to be a big deal this year around all kinds of things, but including specialty drugs. And also, what's going to happen now that the COVID treatments and vaccines and such are not going to be picked up by the government. So that's one big area. Benefit design is always something I'm watching, how are employers going to resolve this. There's an interesting court case out of Texas that might change some of the so-called free preventive care copays and what's going to happen with that and how will employers react depending on how that turns out. And finally, the last couple of years, we've seen a lot of push for price transparency. So insurers and hospitals have posted a lot of price data. So I think we may see some additional rules around that to try to make it a little more useful for consumers and researchers. So I'll stop there. And I think you have a lot of questions and the folks in the audience do too.
Thanks, Julie. Well, let's stay with you. The public health emergency triggered by COVID-19 will end on May 11th. So how do you think the private sector will respond to that?
Well, it really depends what happens. What we've already seen is that the drug manufacturers have said that once these go commercial, which will be when the government purchase supply runs out, they plan on raising the price. So until now, the federal government, as you know, has been purchasing COVID-19 shots, for example. Let's just start about that. It bought, I don't know, 100 and something million doses of the Pfizer vaccine, the booster doses recently, and they paid about $30 a dose. And Moderna's, they were paying about $26 a dose, something in there, the last purchases. But both Pfizer and Moderna have said that they're already planning on raising the price to about 110 to 130 per dose. So that's going to be their list price. What they actually get paid may vary. Insurers and employers may be able to negotiate a different price than that, a lower price, but that's substantially more than folks are paying now. And I think we may see the same thing with some of the treatments. Paxlovid and that kind of thing. So the cost is going to go up and the question is going to be who's going to pay that. When the federal government supply runs out, that's going to fall on employers and insurers. And we don't know yet what that's going to do in terms of premium costs, but you can kind of imagine that those costs are going to get passed through. Now for consumers, for you and I, when we go to the doctor, most people with insurance are going to continue to get their shots, their vaccines covered without a copay. There will be differences based on the kind of insurance you have. And then with treatments and those at-home test kits, that's also going to vary depending what kind of insurance you have. But some people are going to have to start paying either a copay or the full price of those at-home tests or the treatments. And again, it varies by the kind of insurance you have, and it may also vary a little bit by state. Some states are making a little bit different rules. So that's a long answer to a short question, but it's going to be something that everybody's going to be grappling with sometime after May.
Thanks, Julie. John or Maya, anything to add?
I think she hit on it. It's going to be a huge thing to watch in the next year, the thing to watch in the next year.
Great. So Maya, yesterday, the Biden administration announced 3 new drug pricing policy experiments that would standardize how much Medicare patients would pay for certain generic drugs and pilot new ways for Medicaid to pay for pricey cell and gene therapies. How do you think these policies will roll out during 2023?
Yeah, so I think it'll be really interesting to see how CMMI decides and CMS in general decides to go forward with these. It seems like they're both of those two programs are still fairly far off in the future. And it seems like there aren't the exact timelines in CMMI's plan that they rolled out yesterday, but it seems like maybe 2025, 2026 is more where we're looking at for these things. But yeah, I think they could be really interesting they could change a lot for consumers, especially in the Medicaid market where the Inflation Reduction Act didn't touch on them. And so I'm excited to see it. CMMI models are always interesting to watch because they're temporary by nature, and unless, the administration or Congress decides to make them permanent, but that's pretty rare. And they also are experiments. So they test things. Those two programs will probably be voluntary. So it'll be interesting to see who participates and what data the government gathers from that. And then there's a third one, maybe John, the accelerated approval expert, you might want to talk a little bit about that third program that they're envisioning.
Go ahead, John.
Yeah, so and I mentioned this a little bit obviously at the top. It looks like they'll probably figure out a way to pay less for accelerated approval drugs until they get confirmed. Congressional Medicare advisors, I'm talking about MedPAC here, they have proposed in the past making drug companies pay rebates back to Medicare on accelerated approval drugs. That was the way that MedPAC thought it could be, just done, because, the CMS has, I don't understand this, but they have systems, and they you can't just say, okay, we're going to pay less for these drugs. You have to figure out how to do that. So it would be operationalized in that way. At least that was how MedPAC suggested doing it. Yesterday, when HHS officials announced this, they made it clear that there's a lot to work out here, and that's just one option among many that they're going to be considering. But yeah, this is the accelerated approval demonstration is really interesting because the main criticism of the accelerated approval program, I think, has been that FDA at times has had difficulty getting drug companies to finish confirmatory trials. And also it has had, in one case in particular, a difficult time getting them to take drugs off the market when those trials finish and they don't have good results. So this is a way, yet another way to kind of tighten the screws on drug companies to get their confirmatory post-market trials started before they get their accelerated approval, and to get them to finish it on time. Having said that, both CMS and FDA officials have been pretty clear that they're going to allow some leniency. The FDA officials said that they're not planning to like have a concrete rule that 100% of the time companies have to enroll clinical trials before accelerated approval. There might be situations in which that's not feasible. So FDA is it's going to use its discretion for what that's worth.
Thanks, John. It's been surprising to me that you can have accelerated approval at the FDA because the drug is urgently needed, and then you can have a long coverage with evidence development process at CMS where people don't actually get the urgently needed drug until they generate evidence that the FDA didn't require. So I'm interested in following that and seeing where that goes. On the drug prices, for the Inflation Reduction Act, there's going to be a negotiation between the federal government and the pharmaceutical companies, but it won't start until 2026. John, can you let us know where are they in that process right now?
Well, they're trying to hire people, and they're going to allow for a lot more public input than had previously been thought, I guess. I don't know. The law doesn't really require much in that area, and CMS has made pretty clear that it will get a lot of stakeholder feedback as it's developing this. So yeah, there's just a lot to do. A lot of it can be done via guidance. They're trying to get it up and running in time to avoid it being undone by Republicans. So September 1st, again, will be the date for the first list of 10 drugs that they're going to negotiate. So that's the big next thing. And there will be a lot of, guidelines and so forth that are published throughout next year as they, figure out how they're going to do this.
Thanks. And then I have one more question on the drug pricing, and we'll give it to Maya, and then we'll go back to Julie on a different subject. So Maya, some people are projecting that negotiation between the US government and pharmaceutical companies could somehow actually raise prices. Have you heard that? And how would that happen?
So I'll let John jump in after this because he was following this much more closely than I was. But I think that what those people are getting at is that pharmaceutical companies have argued that price negotiation will stifle innovation and make sort of create disincentives for companies to continue to create and invent new pharmaceuticals. I think there's also been some evidence that that won't happen. We haven't rolled this out yet, so we don't know for sure. Definitely companies are sounding the alarm about it. So I'm definitely will be watching to see what happens there.
John, any thoughts on that before we move over to Julie?
Sure. Well, the Congressional Budget Office said that the inflation rebates are actually what it thinks will contribute more to rising drug prices than negotiation. Though generally, when people talk about the law, they talk about the law as a Medicare negotiation, and they're intertwined, right? So yeah, I'm not saying that Medicare negotiation is not supposed to, in some cases, lead to higher prices, because it is. It's just that CBO, the Congressional Budget Office, nonpartisan budget wonks in Congress, they think that the inflation rebates will lead to higher launch prices because given that you can't, raise your price faster than inflation, that means you're going to launch high. CBO also said that Medicare negotiation is so far out, especially since drugs are going to be on the market for 9 to 13 years before they're subject to it, that it's kind of difficult to determine how much of an impact that will have on prices. And it's far enough out that drug companies also aren't necessarily factoring that in as much as people might think. Having said that, there were some, again, back to MedPAC, these congressional Medicare advisors, there were a couple of MedPAC members who said that they think that negotiation could lead to higher prices in the 6 protected drug classes. I don't have those memorized, but it's HIV is one of them, cancer drugs. Since those protected drug classes aren't subject to negotiation, I think that's the deal. You might see more price increases there to try to offset losses elsewhere. I was getting ready to look up the story I wrote on that, but I didn't have time to find it before answering that question. That's roughly it. Don't hold me to that, every word I just said, if I was wrong about some of that.
Thanks, John. So, Julie, in one of your recent articles, you cited trends showing that enrollment in the Affordable Care Act continues to grow. Do you think this will continue, or is it already peaked?
Boy, that's hard to say. I think that what we've seen is the subsidies have really helped push a lot of people to enroll in marketplace coverage. And those subsidies came about because of the pandemic, and Congress approved additional subsidies. So this basically got rid of that cliff, they called it, when you hit 400% of poverty. If you made $1 more than that 400% of poverty level, you didn't get a subsidy, and your insurance could get very expensive. So that was phased out. And so now people who earn more than 400% of poverty can still get a subsidy if their insurance is going to cost them more than 8.5% of their household income. So that got a lot of people to enroll, and those subsidies are continuing to 2025. So I think we'll see those folks stay on. The question is, what's going to happen in 2025? Will those be removed? I mean, it's pretty hard to take away a benefit once you've given it, but these are taxpayer dollars, so there could be some discussion about budget cutting and the need to pull this back. I think that's going to be very curious. But look, we're also going to see a lot of people losing coverage in this next year through Medicaid. Some of those folks are going to be eligible for a 0 or very low cost Affordable Care Act plan, depending on their income, with these subsidies and the enhanced subsidies. So that could also help boost enrollment. So I think it's going to stay high for a while, but it's really hard to tell.
And do you think that with the upcoming sort of Medicaid, revisiting the eligibility and potential for mass disenrollments. Do you think that would result in a lot more people choosing to sign up for the health plans in the marketplace? Or what happens once those people are disenrolled from Medicaid?
I think a lot's going to depend on the outreach to those folks and what kind of, I mean, how are they going to find out that they're eligible? I know a lot of states, it's going to vary state by state too, right? So how many states are going to have big programs, try to encourage people to sign up? What are insurers going to do? They're going to need to find out, first of all, that they've been disenrolled. They may not know that until they show up at the clinic or the pharmacy counter and find out that they're not enrolled anymore. Some of these folks may have moved. They may not get the notification. Some of them may have higher incomes. Maybe they have jobs now. Maybe they'll have job-based coverage. Maybe they won't. But I think a big question is going to be, what's going to be the outreach? What are going to be the resources available to them to let them know that, hey, you might be qualified for this other kind of plan. You're eligible. Here's a way to help you enroll. Now, remember, the Biden administration also increased the funding for navigators and assisters. So there's going to be more of those types of folks out there, perhaps helping people. But a lot, again, is going to depend on what happens in each individual state, and maybe even to some extent, will the insurers put out some kind of marketing effort?
Thank you. And then changing subjects a little bit, you've also written about the ongoing obesity epidemic in the US and the potential benefits as well as the downsides of some of the new medications. Where do we stand on fighting the obesity epidemic in the US?
Well, there's a lot of interesting stuff going on about that right now, right? So we've got these new drugs that one of them is called Wegovy, and it's basically it's a higher dose of a drug called Ozempic, which treats diabetes, and it has shown substantial weight loss. And there's another one on the market, and I'm blanking on the name right now, I'm sorry, but there's another one that's recently come on the market, and these show substantial benefit, what experts tell me, over earlier weight loss treatments. And we're talking like 15 or 20% of body weight loss, and that's big. That's comparable to sort of bariatric surgery without the surgery. The problem is they're expensive. They're $1,300 a month or so, okay, depending on your insurance. So if you're an employer, are you covering this? And some of them are not, and some of them are. It's going to be a very large bill if these drugs become very widespread and commonly used, because we have a lot of concern about obesity in this country. We have a lot of folks who are in that category. So will these become widespread? Will insurers pay for them? Will employers pay for them? Right now, we also have a situation where a lot of sort of influencers and celebrities are using it for perhaps more moderate weight loss. And so there's a shortage of this drug. For folks who have diabetes, they might be having trouble right now getting Ozempic because some people are using it off-label to lose weight. So there's a lot going on around that, but I think the story that I wrote about was what will happen with coverage costs, and it's going to be expensive. Let's say, you've got 20 or 30% of your workforce that would qualify for this, and it's, let's say $1,000 a month. That could add up for an employer. So that's going to be very interesting to watch as more of these come on the market. Maybe there'll be competition. Maybe the price will come down. Maybe not. So I think that one is something that employers are watching in light of a lot of these specialty drugs. It's not just the weight loss drugs, right? We've got a lot of fabulous new products that are very, very expensive, and people are using them. And so employers are trying to figure out, what do we do about this? I recently wrote a story that was looking at different payment models. And it's a little ironic because there's these programs that employers really don't like. I'm sorry. And that they don't like before. They were paying the co-pays for their workers. The drug companies would pay the co-pay so that the worker would stay on the brand name drug. Employers didn't like that, but now they're tapping into those programs. They said, hey, you know what? We're going to tap into those, even though before we really thought that was encouraging people to stay on more expensive brand name drugs when there might have been a generic alternative. Now they are working on a couple of different programs where they get the employees on those programs. They deem the drugs non-essential benefits, And then they can charge the copay, they can raise the copay that that patient would have to pay. Now, the patient doesn't pay that copay, but they tap into the drug assistance copay and get the maximum amount that possible that they can, and they use that to offset their own drug costs. So some employers are doing that. And there's another version that's a slight twist on that, where they just don't cover the drugs at all in their health plan, and then they refer the worker to a charity program to pay. So both of those things have been going on. There's been some pushback. There was recently a lawsuit filed by a group of patient advocates and other groups objecting to when these copay programs are used, they don't count towards the patient's out-of-pocket max, and they want that counted so that the patient doesn't have to be on the hook. So that's a very complicated area, a lot going on with that. We're going to have to watch what they're doing, but that just shows, I mean, employers and insurers are trying to figure out how they're going to deal with these rising healthcare costs, and so they're trying to tap into whatever programs they can to lower their costs, and I think we'll see that playing out over the next year as well.
Thanks, Julie. Now, going back to Maya, during the COVID pandemic, the federal government extended a lot of flexibilities to how people can receive healthcare that formerly weren't available, for example, through telehealth. What do you think are going to be the lasting breakthroughs from these kinds of flexibilities as a result of the COVID pandemic?
Yeah, I think that COVID has completely changed the way that our healthcare system operates in a lot of ways. Telehealth is already a lasting impact. I've heard all the metaphors you could think of. You can't put the toothpaste back in the tube. You can't put the horse back in the barn. It goes on and on. But I don't think that consumers are going to give up using telehealth. And I don't think that providers want to lose that flexibility either. And Congress has already extended it for 2 years after the end of the public health emergency. So we know that we have Medicare telehealth flexibility until mid-2025 at this point. But I think what I'm curious to see is how, after that point, how payment for telehealth looks. Will Medicare continue to pay for telehealth at the same rate that it pays for other in-person services? And what about other payers? How will that look? Will the rates continue to stay, pretty much where they are, or will they go down or go up? It'll be something to watch very closely. And I know that a lot of people are doing research on this, and also fraud and abuse with telehealth, how that affects the program. I think other things from COVID that are worth watching are hospital at home, which sort of goes along with telehealth, how that's also been extended for a little bit after the public health emergency, that program, but how that continues to develop, and whether private sector companies are going to make more investments in that now that we have a little bit more of a timeline for using that program. And then there have been a ton of administrative burden waivers and just things to make hospital operations and provider operations easier over the past couple of years. And a lot of those unwind with, almost all of those unwind with the COVID public health emergency ending. So which of those are providers pushing to get extended, and which of those will Congress actually extend? I'm not sure yet. The American Hospital Association has released their sort of idea of what they want. It'll be interesting to see if anything happens on that. I don't know that there's going to be that much enthusiasm in Congress for extending any of these other things, but some of them CMS can do on their own, and it'll be interesting to see how hard groups lobby on that.
And Maya, in your opening statement, you mentioned some areas of must-pass legislation. Briefly, I was wondering if you could go into a little bit more depth on what you see as must-pass legislation, as well as some of the healthcare priorities that didn't make it into the year-end omnibus that might get a second chance sometime this year.
Yeah, I think a lot of these programs that have healthcare programs that have funding from the federal government that are, relatively bipartisan and uncontroversial and have been seen to help patients and providers are when their funding is up, it's not that much of a question if Congress is going to reauthorize their funding. More, it's a question of, are they going to increase their funding, and do they make any changes to the programs or add any other small policies to the package that's reauthorizing the funding? So a big one that I'm looking at is the PAPA bill, Pandemic and All Hazards Preparedness Act. This is the first time that program is being reauthorized after COVID. So it'll be interesting to see if that changes things. COVID has sort of politicized pandemic preparedness and public health. And so how does that affect the conversation there? And I'm sorry, what was the question? Was I answering the
No, you just mentioned PAPA is part of it, but then there's a couple of other things that need to be reauthorized, like the Support Act.
Yes. Yeah. Yeah. So the Support Act is opioid epidemic policy, and there's a delay of cuts to some safety net funding that was included in the Affordable Care Act, and then funding for community health centers. And you also, asked about what could be included in these reauthorizations that missed the boat in the end of the year funding package. I'm interested to see if any of a lot of the public health pandemic preparedness things made it in, but do some of those, like CDC reforms, get attached to PAPA? Definitely possible. And some of the more mental health, opioid use disorder policies could get attached to the Support Act reauthorization as well. So those are the big things.
Thanks, Maya. And then Julie, after this one, we're going to turn to some of the audience questions. But before we do that, where do we stand in terms of healthcare cost transparency? And can a patient really know in advance what the cost might be before their treatment?
Yeah, that's a difficult one to answer as well. We have a lot more data now. You remember the last couple of years that insurers and hospitals were required to post their prices, and these are the negotiated prices they're paying for their services. Insurers, for example, also have to include a list of like 500 shoppable services, meaning, you need a hip replacement. So you can look online and see what the heck that is. Otherwise, it's kind of like a la carte and you have to figure it out. So it's really complicated. Many hospitals have not fully complied and haven't posted all of their negotiated prices with all of their insurers and or their cash prices. They might still have their charges up there, which, as we know, are kind of like the list price that people don't necessarily pay. So hospitals still kind of a mixed bag. The insurers have released a lot of data. And in fact, they've released so much data that even researchers with great big giant computers are having a hard time downloading it and synthesizing it. I think the thought was that entrepreneurs and researchers would be able to take this data, put it together, and then you and I could go on some handy website and say, yeah, you know what, I got to get an MRI of my knee, and then I'm probably going to have knee surgery after that. So how much might that cost me? And you'd be able to find out ahead of time. That's not really how it's working out right now. It's a little more complicated. That said, many hospitals, insurers have their own tools that you could maybe look up the cost of something. And you can also, if you are uninsured this year, you can request an advance cost estimate, and they have to give that to you, and it's got to be within like $400 of their estimate. Otherwise, you can take it to a dispute. So that's happening. If you're insured, there's going to be something called an advance estimate of benefits. The final rules have not come out on that yet. So the long answer is you can get some information. You can get a lot more than you used to be able to. You can go on some websites like Turquoise Health and a few others and look up some costs. But whether you'll get an exact estimate or even close to what you're going to pay at any provider or hospital, I would say no, you cannot yet. You might be able to get some idea at many places, but it's challenging. So I think we're going to see perhaps sometime this year some additional clarification or regulations or guidance. I'm not quite sure what it's going to be, to try to streamline this data and maybe make it more standardized for the insurers to put out there, so it's a little bit more easy to use. And I think we may see some guidance on these advanced estimate of benefits from your insurer. That's still up in the air. So I think that's going to be something to watch this year. How is that going to play out, and will people be able to use this? So long and short is there's a lot more data out there. You can find out a lot more. Is it perfect? No, it's still evolving. And a lot of times it's almost too much data to be useful.
Thanks. Well, it would be great for patients if they knew what their out-of-pocket obligation was going to be for a surgery before they went and had the surgery. I still see, tons of bills coming in from people that, you don't even know like what their role was. And somebody must know. So that would be a great help to patients, I think, if they could know upfront what they're on the hook for. So now we have time for a couple of audience questions. One is, the first one's from Jennifer Bright. Jennifer, it was great to see you at the Health Leadership Conference. And for those of you who don't know Jennifer, she's the chair of Mental Health America. So Jennifer's question is, at a time when representativeness in clinical trials is equally in transformative mode, in other words, improving, how can we make decisions on effectiveness and value of emerging therapies while we're blind to differences based on gender, race, ethnicity, and social determinants of health? And I'll open that to whoever on the panel wants to volunteer.
I'll jump in large part just because I want to correct myself. So I'll get to that question to the extent that I can. I said earlier that drugs and protected classes aren't subject to negotiation. That is wrong. Yes, they are. Sorry about that. There was some other point that the MedPAC commissioners were making about there not being additional tools that insurers can use to control prices of those drugs. That, coupled with a $2,000 cap on seniors' annual retail drug spending, means that you can raise the prices without sacrificing demand for those drugs. But anyway, as for setting a price for a drug without having real good information on, sorry, my phone was going off. They're trying to improve, representation in clinical trials. They've been trying to do that for a long time. I would point out that, obviously you have lots of people with different, obviously you have people of both genders and people who are gender fluid in Medicare, but Medicare is setting prices for the Medicare population, and they do take that, they heavily weigh that when they're trying to determine whether they should cover something and how widely they should cover it. It's very much specific to the Medicare population, which includes, of course, people with disabilities, which often gets overlooked. People just think of it as for seniors, and there are a lot of people out there with disabilities who get their insurance from Medicare. But yeah, I mean, obviously it's tough to determine what a price should be, and I'm sure they're going to take that in consideration as much as they can. I will point out that at the very least, they're not relying on prices that are set by other countries, which have often different makeups. I can't imagine setting a price, for instance, for a sickle cell drug based on what the Japanese pay for drugs, because sickle cell anemia is mostly affects people of African descent. I don't think there are a lot of those folks over in Japan, and I don't think that would be a good way to set a price for that drug. So yeah, it makes it difficult, but that's not going to stop them from setting the price. I mean, again, it's a price. That's it. It's just a price. So like, if they set the price based on how it works in most of the people, that doesn't mean that they're not going to sell it to people who, or they're not going to cover it in people who have disabilities, or, or based on their racial or gender, based on their race or gender. But they're just trying to figure out how much they're going to pay for it.
Thanks, John. Interesting question. It sounds like even if it has a single price, it might have a different value based on different social determinants of health. And it would be interesting to see how the agency considers that, since reducing health disparities is one of their top priorities. So we'll stay tuned on that. The next question is from Robert Bennett. Medicare payments to physicians have not kept pace with inflation over 20 years. Is this the year Congress permanently addresses Medicare payment cuts to physicians? And I believe Robert is with the Texas Medical Association, if I'm not mistaken.
This is within my wheelhouse. I can jump in here. Great question. In my opinion, the short answer is no. I don't think that this is the year, because that's a huge policy conversation that takes a lot of finagling and a lot of conversations. And so I don't think that that's something that Congress will have the bandwidth to do this year, but I do definitely see lawmakers interested in starting that conversation. And so I think that we'll see a lot more interest in it and sort of getting the ball rolling. And then I do think that in maybe a year from now or 2 years from now, that could be a very real conversation to have.
Thanks, Maya. And the next question is from Roger Smith, who, when last I spoke with him, was with the American Association of Marriage and Family Therapists. And so obviously, telehealth has been a big boon to enabling people to access psychotherapy. Do you foresee any push by the administration this year on addressing interstate telehealth barriers? And if so, what model would they advocate for as a solution?
It's a great question.
You want to give that a try, Maya?
Sure. I don't know. I haven't looked into exactly what the administration wants to do or what people in Congress want to do, but I definitely hear stakeholders talking about this a lot. And so I should make a note to myself to look into that. I think it will be a big conversation, and I'm interested to see how it plays out. Feel free to send me an email if you have any thoughts.
Thanks, Maya. And then from Deborah Outlaw, there's 2 cases pending before appellate courts on the 340B drug discount program regarding contract pharmacy issues. So for those not as in the weeds, the 340B drug discount program is a program that enables hospitals and some other types of providers that meet certain criteria to buy deeply discounted drugs and make them available to patients of their organization. But it's been criticized as perhaps being abused and over broadly used beyond the intended population. So with the cases in front of the appellate court, Deborah is asking, what does the panel see as the odds that Congress steps in to refine the 340B program?
I could take this one too, unless anyone else wants to jump in, but I would say 50-50. I am very curious to see if Congress jumps in. I think some, I've been talking to a lot of community health center stakeholders recently, and it seems like they're kind of split on if they want Congress to step in. 340B stakeholders in general, I guess, are kind of split because some say that it could lead to a favorable result for the 340B entities. Some say don't mess with it. The courts are very split. So I don't know. I'm curious to see what happens. I wouldn't be surprised if either way. So it's just something to watch at this point. I haven't heard any lawmakers say that I've heard people say that they're interested in it, but I have not heard anyone say that they are ready to take action or even, hold a hearing. So we'll see.
Yeah,
well,
I'll jump
ahead,
in.
John.
Yeah, I don't disagree with the 50-50. I would never put odds on anything, but it is an area that they might work on. I will say that. I don't remember which case it was, but there was a case that recently that the drug company won on this one. If more of these cases are won, if more of these lawsuits are won by the drug companies, I would think, I haven't heard anybody say this, but I would think that would put a little bit more pressure on the hospitals to try to compromise on something. This one requires a lot of compromise. The 2 sides are really far apart. That doesn't mean it can't get done, but usually legislation is very pro drug company on this because it's reforming it in a way that would help the drug companies. And the hospitals will want something that gives them stuff too. So I don't know what the chances of that are happening. I know that there is an organization out there that's proposed a middle ground already. So I don't know if anybody's taken that up, but it could happen.
Well, thank you. And that'll be our last question, but I wanted to turn it over to our panelists and go one at a time like we did at the beginning and ask if they had any final thoughts or something really important that the audience ought to remember from today's session. So let's start with you, Julie.
Well, I think final thoughts. I think again, the main area that I cover, I think it's just going to be so interesting to watch the issue of pricing for drugs, for the COVID treatments, for all that kind of stuff. How is that going to play out in terms of employers and insurers over this year? What are we going to see there? I think that's something to watch. I think that we're going to see a lot of very interesting benefit designs continue to be tested by employers. Some of them are going to work, some of them are not. How is that going to play out for consumers? I think that's probably what I'm going to be focusing on a lot of this year.
Thanks, Julie. And John, a final thought?
Yeah, I don't think it was brought up because I don't think you guys cover the Food and Drug Administration much, but the veterinary user fees are coming up this year. That's potentially a vehicle for some healthcare things. Just keep that in mind that PAPA is not the only one. I don't think you should take your eyes off of drug imports. I have no inside knowledge on what's going on there, but it's still out there. And, you have states that have sent their plans to FDA to import drugs. And so we'll see if that happens. And then I would just say, just in general, antitrust regulation is becoming more visible. So you should pay attention to that too.
Thanks, John. And Maya, you'll get the final thought.
I would just say don't count out Congress this year. A lot of people, like we talked about at the beginning, have said, oh, nothing's going to get done. There's so much gridlock. Whether things get over the finish line is definitely an open question, but there's still going to be a lot to talk about in healthcare in Congress this year. And then also, I touched on this at the beginning, but we didn't get to dive into Medicare Advantage that much. That's something that I'm personally watching very closely. CMS has started to be a little bit more aggressive on their oversight of plans, and plans are definitely fighting back. Insurers are fighting back. So that's definitely an area to watch.
Thank you all, and also to our guests for joining us for today's session. 2 reminders: Applied Policy has a monthly newsletter that discusses timely healthcare policy topics. If you're interested in receiving our newsletter, we have shared a link in the chat for you to join our mailing list. Secondly, material from today's discussion will be posted shortly on the Northern Virginia Health Policy Forum website and on YouTube, if you'd like to refer to any of its content. Thank you all for being here, and thank you to the Applied Policy team and Lauren Fresconi for all their help in making this possible. And I look forward to seeing you at our next event next month. Thank you all.